fortunate to lead on the ISWA guideline on the role of ultrasound in congenital infections. There's a lot to cover, and we have an hour, and we're really keen to have enough time for questions at the end. So this is the guideline, which is due to be published in July issue of the Wide Journal, and it's usually free to download. And I think I'd encourage you to translate it into Arabic, so that actually people people can actually access it easily. So I'm going to start with how do we often pick up congenital infection or diagnose it? Because screening for congenital infections in pregnancy is not something that we do routinely, and different countries have different practices. The common scenario is the fact that you do ultrasound scan, you see something on the ultrasound scan to make you suspect that there may be congenital infection, you go and test the mother or test the fetus and then make the diagnosis. And therefore, it's really important that we know which ultrasound signs, if we come across that you suggest or suspect that there might be congenital infections, you go and test for it. I'm going to divide it into 3 groups: cranial abnormalities, so brain problems, extracranial, affecting the rest of the body but not the head and the brain, and then other abnormalities that affect the placenta or the amniotic fluid. So the cranial abnormalities, obviously ventriculomegaly, which is something that we often pick up easily on the ultrasound scan, whether the second or the third trimester, and calcification, and you can see that on the ultrasound image here on the bottom left corner. You can see this white spots or white dots there in the brain. Intraventricular synechia or adhesions, and you can see that on the right-hand side. You can see this is ventriculomegaly. You can see that the fluid spaces in the brain, but also you can see some adhesions there. And cerebellar abnormalities, including Vermian hypoplasia or cerebellar hemorrhage. Also could be periventricular pseudocyst. So if you here, for example, the image of the ultrasound scan, the one on the second from the right, you can see that here there is a cyst inside the ventricles. Malformation of cortical abnormalities like lissencephaly, smooth brain, polymicrogyria, schizencephaly. And for these abnormalities, I think you need to have a good experience of neurosonography to be able to pick it up on ultrasound scan. And it's likely that you might actually be able to pick it up better on MRI. And of course, microcephaly. What about extracranial abnormalities? So things like ascites, and you can see this ultrasound images there showing pericardial effusion, you can see cardiomegaly, skin edema or hydrops, or signs of fetal anemia in the absence of maternal atypical antibodies. So if a woman have anti-D antibodies and you have anemia or hydrops, well, the most likely explanation that the baby is hydropic because of the antibodies or because of anemia. Well, actually, if you have fetal anemia in the absence of atypical antibodies, always think of possibility of congenital infections. Other things, small babies. So if you have small gestational age, think of congenital infection. And certainly in the UK, it's a common practice that we will do torch screen for small babies. Hyperechogenic bowel. You can see this picture on the second from the left, like bright echogenic bowel. Hepatomegaly and splenomegaly, and often people will ask, how do you actually define or when do you decide that there is hepatomegaly or splenomegaly? So the picture on the left-hand side, you can see the spleen is quite big, it's quite striking. And splenomegaly is when you have the measurement is more than 3 centimeters. Hepatomegaly, which is the picture on the right-hand side, and this is when the length of the liver and the longitudinal sections more than 4 centimeters. Or if you have liver calcification, so dots, white dots, calcification in the liver. The third category is placental amniotic fluid abnormalities. So if you have placentomegaly or thickened placenta, how you define that? When the thickness of the placenta is more than 4 centimeters, or if you have calcification in the placenta, diffuse calcification, if you have oligohydramnios, and sometimes if you have polyhydramnios, however, that's quite rare. But if you see that on ultrasound scan, just make sure that you test the mother for torch screen or think of congenital infections. These are, again, scenarios other than finding ultrasound abnormalities that makes you, or you should think about the potential diagnosis of congenital infections, including if you have a non-vesicular rash in the mother or symptoms of systemic viral infection, think of rubella or parvovirus. If you have facial rash characteristic, the slapped cheek, so on the cheek, think of parvovirus, or a history of significant exposure to viral illness or specific infection. And of course, the typical example would be Zika, which is obviously no longer a major problem. But if the mother say, well, I had significant exposure to a child with chickenpox or whatever infection, in this case, you test the mother for the relevant serology. So I'm going to go on and go through individual infections. So we start with a congenital CMV. It is the most frequent congenital viral infection. The prevalence will vary, but let's say it's about 1 to 2% of all live births. Why is it important? It's the leading infectious cause of sensory neural hearing loss and mental retardation. Vertical transmission rate varies whether it's primary infection or secondary infection. If it's primary, it's in the region about 30 up to 50%. Secondary, much less, it's about maybe 2 to 3%. Why is it important? Because, or maybe you can argue as well why some people say it's not important to screen for, because 90% of babies or fetuses that have congenital CMV don't have any symptoms at birth. So, some people would say, well, but it's not a big problem. 90% of them don't have problems. But on the other hand, 10% of them will be symptomatic at birth. And in this group of babies, the risk of mortality is high. It's about 15 to 30%, and 90% of them will develop complications. Of those who are born and asymptomatic, about 10 to 15% of them will actually develop symptoms later in life, most commonly sensory neural hearing loss. How to diagnose the fetal infection? Well, the only way really to diagnose it is by doing amniocentesis and sending the amniotic fluid sample for CMV PCR. And as I mentioned, the screening certainly in most countries is not routinely recommended, but there are a few countries that do screening commonly for CMV. And the prenatal diagnosis, as I mentioned, and I spent the first 5 minutes talking to you, is often by ultrasound abnormalities because it's asymptomatic or mild infection in the mother. It's often that you do ultrasound scan, you detect or you pick up that one of these abnormalities, and therefore you test the mother or the fetus. So if you take the pregnant woman, about some of them will already have had CMV in the past, and therefore they are immune, but about 20 to 60%, depending on your population, this woman or pregnant woman never been exposed to the CMV before, and therefore they're called susceptible. Obviously, the group that are susceptible are the ones that are more likely to get primary CMV or seroconversion during the pregnancy, and this is a group that will have the highest problem. So of those group, the rate of seroconversion during the pregnancy is about 1 to 4%. And the one that seroconvert, they get primary CMV infection, 40 to 50% will transmit the virus to the fetus. And of those, about a third of these babies will have symptoms or problems. The one that are immune, which as I said, about 40 to 80%, depending on the population, about 0.5% of them will actually get congenital infection, whether they actually get secondary infection or reactivation. And in this group of fetuses that had the congenital infection, less than 10% will actually have symptoms at birth or problems. So how to diagnose maternal primary CMV infection? Well, the key thing is seroconversion. So this mother was negative and then become positive during the pregnancy. So which serology we look at? Obviously the CMV, IgG and CMV, IgM. And generally speaking, with congenital infection, the rule is that the IgM is really difficult and tricky to interpret, while the IgG is much better and more reliable. So if the woman did not have IgG at the beginning of the pregnancy and at some point converted, so became CMV IgG positive, that's a diagnosis of primary CMV infection during pregnancy, maternal primary CMV infection in pregnancy. The other thing is that if you detect CMV IgM antibodies with low IgG avidity, the IgG avidity is a test that looks almost about how mature these antibodies. And the rule is that if you have low avidity, less than 30%, that means that the infection occurred within the preceding 3 months, while actually if the IgG avidity is high, that means that actually the infection occurred more than 3 months ago. But generally speaking, I think it's my advice during the CMV, that was sort of the congenital infections talk, is that when you interpret the serology, it's useful to have a discussion with a virologist or someone who's specialist so that you can get advice. So certainly I work in the UK, we tend to work in a multidisciplinary team, and therefore this case is often we discuss it with a virologist. And what about how do you diagnose maternal non-primary CMV or secondary CMV infection? And it's really difficult because they already have IgG, with often have high avidity anyway. So anyway, in this case, it's impossible. You cannot exclude maternal infection, secondary maternal infection using serology. And therefore, you only have to do amniocentesis to diagnose congenital CMV in a baby or in the fetus. I've got a couple of cases to show you. That's often sort of a common scenario really for congenital CMV. So this is with the first pregnancy. The first trimester ultrasound scan was normal. There was no history of fever, maternal fever. And then she came for the ultrasound scan and anomaly scan, so 23 weeks. And then the scan showed small head, you can see that, ventriculomegaly, small cerebellum, ascites, and liver calcifications. Of course, you suspect congenital infection, you do amniocentesis, and the CMV PCR is positive. And of course, because the baby have lots of abnormalities, and therefore the risk of symptomatic CMV is quite high, and therefore the woman is counseled and opted for termination, which is obviously a legal option in the UK. Another case, so this was the second pregnancy. Again, the first trimester ultrasound scan was normal. The second trimester ultrasound scan was also normal, and no history of fever. And as I mentioned, from my experience, a lot of these women do not really have history of infection or maternal systemic viral disease or being unwell, for example. And then she had ultrasound scan at 29 weeks, either because, for example, reduced fetal